Hello and welcome to this, the 10th and final lecture in the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. I'm very excited that you've made it all the way to this last lecture. So before we begin, let me take a second to thank the agencies and associations that have made this lecture series possible. And as you know, this includes such wonderful agencies as the Pacific Island Health Officers Association, the University of Arizona Zuckerman College of Public Health, the Western Regional Public Health Training Center, the Pacific Island Public Health Training Center, and of course the College of Micronesia FSM Public Health Training Program. Now in this final lecture, we will be talking about how to select NCD interventions. This, of course, is the whole purpose of collecting epidemiological data on NCDs in our jurisdictions, or to ultimately develop interventions that are based upon this data. So in this lesson, we will talk about 3 different frameworks we can use in selecting interventions, including the causal model, the health impact model, and the behavioral models and theories. We will then talk about how to go about identifying interventions that are based upon good evidence. In other words, they have been shown to work already. This will involve the use of the community guide, which I'll introduce you to a little bit later in this lecture. Then we will conclude by talking about non-evidence-based factors that you need to consider when choosing interventions, such as access to financial and other resources that might be available or not available to you in your local jurisdiction. As I mentioned before, there are different frameworks that can help you determine potential interventions that can be used to address NCD-related public health problems where you work. These include Causal Pathway, CDC Health Impact Pyramid, and finally, behavioral models and theories. I want to point out that these frameworks are not mutually exclusive and can be used in combination with each other. For example, causal pathways and behavioral models and theories might help you assess what outcomes you would like to change and how particular interventions might help you change those outcomes. The Health Impact Pyramid allows you to consider potential reach of your interventions. And evidence-based interventions help you assess your level of certainty that particular interventions will help change certain outcomes. The last part of this lecture will focus on how to research evidence-based interventions to help determine whether or not a type of intervention has been shown to be effective. As public health professionals, we seek to help prevent and control diseases and find which prevention strategies work best. To accomplish this, we first have to identify what causes the disease. However, this can be complicated because during in-depth study, you may find that there are many things that are associated with a disease, such as genetics and environmental exposure, but these are not actually causing the disease. Many researchers and health professionals use the causal model when examining a disease. They want to figure out what is the direct cause of the symptoms and the illness. It is a logical and systematic way to determine what causes a disease without confusing cause with association. Causal pathways can help identify the logical cause of a problem. They can be used to help create hypotheses about diseases and can help program planners understand why a problem or risk factor is important. Now I want you to remember that causal pathway can also be referred to as a causal map or a problem analysis. Here's an example of using a causal map or pathway for a non-communicable disease or a chronic disease. Now we move from underlying determinants to common risk factors to metabolic risk factors to specific diseases. Now usually these maps are not used for general types of diseases as is shown here, but for very specific situations. These causal maps generally do not try to illustrate all causes, but rather selected causes that might be amenable to interventions. So let's talk about each section of the causal map. Underlying determinants are different from common risk factors, which are individual characteristics. Common risk factors can include the social and economic environment that people live in. Underlying determinants are contextual factors of people's environment which cannot be changed. Sometimes they're referred to as environmental determinants. Common risk factors and metabolic risk factors represent the individual determinants of a person's health. Some are modifiable while others are not. Often, risk for a disease begins with a non-modifiable variable, like age, sex, or ethnicity, and then progresses to a modifiable risk factor, such as weight, diet, and tobacco use. It is the combination and order of specific variables which can ultimately lead to a causation instead of an association. Notice that many of the same diseases have the same risk factors and underlying determinants. This can make it hard to create a specific pathway for non-communicable diseases. When we are creating our causal maps for chronic diseases, we are showing that health determinants and risk factors can cause a disease. Causal maps also help us to realize that a comprehensive strategy is needed that integrates the major risk factor and cuts across specific diseases. What we see here is a causal map example for type 2 diabetes, including the underlying risk factors, common risk factors, and metabolic risk factors leading to the disease. If we created a causal map for cardiovascular disease, we would notice similar risk factors. When we focus intervention efforts, such as improving diet and exercise, the incidence of diabetes and other NCDs, such as cardiovascular disease, will be reduced. For example, studies show that improving diet and exercise can lower a person's serum cholesterol. A 10% reduction in serum cholesterol in men aged 40 resulted in a 50% reduction in heart disease. At age 70, there was an average of a 20% reduction. The causal map can help program planners understand why a problem or risk factor is important. Now let us turn our attention to an approach for selecting interventions that can address a health problem and its risk factor. This is the CDC's Health Impact Survey. The 5-tier or level pyramid shows the health impact of different types of public health interventions. There are different versions of this pyramid. Some have more levels. Others are specific to a type of disease or group of diseases. The arrow on the left represents the impact of each level on health. The bottom level has the biggest influence over health, and the top level has the smallest influence over health. The bottom of the pyramid has levels which have the greatest impact on health. Does anyone see a connection to the example on the right-hand side and the examples we gave on our causal model? The answer is that the underlying health determinants are much like the bottom tier socioeconomic factors. These include poverty and education levels, whether you have access to safe and clean housing, and the amount of income inequality in your community. Let's look at each level of the pyramid and give examples of what is meant by each level. Socioeconomic. This could include reductions in violence, reductions in exposure to environmental toxins. Context. This includes public transportation programs, programs to help communities meet nutritional requirements, and so forth. Protective interventions. This would include things like immunization programs, male circumcision programs, and so forth. Clinical interventions. For example, screening for cancer in the community, better access to medications for chronic disease patients such as diabetics, and so forth. Counseling and education. This would include behavioral counseling or therapy, public fitness programs such as public Zumba, for example, school-based health classes and physical education requirements, and so forth. So which of the levels are easiest to change? Why are some levels harder to work on than others? Well, the answer to these questions is that it is usually harder to change the bottom tiers instead of the top tiers. This is because the bottom tiers affect the most number of people in a society. Sometimes people do not understand that health outcomes are linked to factors like poverty or education, and do not think that they are important things to change. The top of the pyramid has examples which are usually smaller time commitments or cost the least to use. This makes them more favorable, but they also have the smallest impact on the societies that we serve. As we just discussed, the health impact pyramid shows that interventions which change the context for individual behavior can have a greater population impact than one-time clinical interventions. Many NCDs can be prevented, have their onset delayed, or symptoms reduced by modifying behaviors. For example, the CDC estimates that by eliminating these risk factors, poor diet, physical inactivity, and smoking, 80% of heart disease and stroke, 80% of type 2 diabetes, and 40% of cancers could be eliminated. Behavioral models are closely tied to interventions and program planning. Using behavioral models and theory for program planning can help you study health problems and develop appropriate interventions for the most suitable target audiences in the places where you work. Behavioral models and theories give planners tools to design healthy behavior and health promotion interventions at 3 levels, including individual level, interpersonal level, and community level. To use these models, we must understand our target audience. So, what is meant by individual level intervention strategies? What is an example of individual level intervention strategies? Individual level intervention strategies often intervene with individuals to change an individual's health, knowledge, attitude, and behavior. An example would be a program designed to help participants incorporate physical activity into their daily routines. I want to point out that individual level is sometimes referred to as interpersonal level. So, what is meant by interpersonal level intervention strategies? What is an example of an interpersonal level intervention strategy? One potential answer is interpersonal level intervention strategies focus on relationships people have with family members, friends, peers, coworkers, neighbors, and others who share behavioral norms and patterns. For example, building, strengthening, and maintaining social networks to improve physical activity, such as creating walking groups and communities. So what is meant by community-level intervention strategies? One example of a community-level intervention strategy would include strategies that are based on the needs and priorities of a specific population within a geographic or political boundary. For example, community-wide campaigns where messages regarding physical activity are promoted through television, radio, newspaper, banners, and so forth. Community-level interventions can address organizational or institutional factors such as rules, regulations, policies, and informal structures that may discourage or promote behaviors. An example would be a workplace or other institution that implements a healthy eating initiative or a chronic disease management program. Community factors. This would include social networks and norms or standards that exist either formally or informally among individuals, groups, and organizations. An example of this would be, once again, a walking group, but it's a walking group that's developed at a workplace site. We also talked about public policy. This would include local or national policies and laws that regulate or support healthy behaviors. For example, we now have a law here in the Federated in Pohnpei that limits the sale of betel nuts to children under the age of 18. Or this could be no smoking laws in public places. In the next slides, we'll discuss examples of theories at work at each of the 3 different levels. Let's start with the multi-level approach. Health promotion efforts should involve a multi-level approach that includes strategies to modify an individual's behavior, organizational behavior, and the physical and the social environment. Because individual behaviors are influenced by many different dimensions, the more levels we use in approaching behavioral modification, the more successful the program will be in reaching and influencing our target audience. We will briefly go over what is known as the socio-ecological model, which is a multi-level approach to health promotion. But this model is actually quite comprehensive, and I frankly would recommend further reading for you in order to fully understand its implications and application for identifying interventions. This model is also known as the social-ecological model. In 1988, Kenneth McElroy and colleagues identified 5 levels of influence for health-related behaviors and conditions. The 5 levels are listed here. These include individual, which equates to an individual's knowledge, skills, and attitudes. Interpersonal, which equates to friends, family, and peers. Institutional or organizational, which equates to organizations and social institutions that individuals are part of. The community level, which equates to cultural values and norms within a community or even within subgroups inside a community. And public policy, which refers to local or even national policies and laws that impact health behaviors. Some models label these levels that influence health a bit differently. For example, the CDC uses a 4-level social-ecological model to better understand violence and the effect of potential prevention strategies. These 4 levels that the CDC uses include individual, relationship, community, and societal. In this lecture, we will focus on 3 levels: individual, interpersonal, and community. Now keep in mind that when I say community, the community is actually made up of the top 3 levels, including policy, community, and institutional, given that those 3 levels have a high impact upon the communities in which individuals are associated. The social-ecological model has some main principles which we will briefly discuss on the next slide. The socio-ecological model emphasizes the interaction between factors that influence a disease at all levels of society, and those are the levels that we just talked about on the previous slide. For example, whether a community can be physically active when the physical environment of that community does not provide safe places for physical activity. In other words, the behavior of the individual is shaped by the physical and social environment of the communities in which they live. Approaches to health promotion should consider the cumulative impact of physical, social, and cultural environmental conditions on the individual's physical, emotional, and social well-being. It is important to remember that an individual's health is influenced by the environment and personal attributes, such as genetics, psychological disposition, and behavioral patterns. One example of this would be a woman with high blood pressure. She might have difficulty following her doctor's low-sodium diet when the restaurants in her community do not offer low-sodium options. Can you think of an example of using a socio-ecological approach to selecting an intervention for tobacco control? How about implementing a smoking cessation program at a work site or local community center where the city has smoke-free laws to support that local work-based intervention? In the next slides, we will take a closer look at behavioral theories at the individual, interpersonal, and community levels. There are several behavioral theories at each of the main levels, and just remember those are the individual, interpersonal, and community level. But this presentation will only discuss one theory for each level. This will include the stages of change, which is also known as the trans-theoretical model, the social cognitive theory, and community organization. We will start with the stages of change model, which is oftentimes referred to as the trans-theoretical model. Now, this is an individual level model. Now, this model states that people progress through 5 stages related to their readiness to change their behavior. These include pre-contemplation, contemplation, preparation, action, and maintenance. In the pre-contemplation phase, the person actually has no intention of making a behavioral change. Strategies that we can use with individuals in the pre-contemplation stage to help them move to the contemplation stage include increasing awareness of the need for change. And then we can also provide personalized information about risks and benefits of either not changing or changing. The next stage we want individuals to progress to is the contemplation stage. Now, in the contemplation stage, a person is contemplating or thinking about making a behavioral change, but they have not yet made a firm commitment to take action. Now, strategies that we can use for individuals in the contemplation stage to help them progress to the preparation stage include motivating the individual, encouraging an individual to make a specific plan of action in which they can change their behavior. Now, the preparation stage involves people who intend to take action within the next 30 days and have taken some type of preliminary behavioral steps. Now, strategies that we can use with these individuals to help them move from the preparation stage to the action stage include helping people develop and implement specific measurable action plans, such as exercising 30 minutes a day. Help the person establish gradual goals that are achievable, such as 30 minutes a day one week, and then within the next week increase that to 40 minutes a day, and so on and so forth. Now, stage 4 is the action stage. Now, in the action stage, the person has changed his or her behavior, but they've only changed their behavior for less than 6 months. Now, strategies that we can use to help an individual move from the action stage to the maintenance stage would include providing feedback to individuals, and this can be positive feedback, providing social support and reinforcements to the individual, and assist them with problem solving. So if they're coming up against specific barriers, how can you help these individuals move past those barriers? And finally, we have the maintenance stage. So the person has changed their behavior for more than 6 months, and in theory, they will continue with that behavior over the long term. Now, strategies that we can use to help individuals in the maintenance stage is we can help them with coping mechanisms. For example, how to overcome social pressure to go back to smoking or drinking or engaging in less desirous behaviors. Providing reminders, all with the idea of helping the individual avoid relapse into the previously overcome negative health behaviors. So can you think of an example of a program that would use the stages of change model? Well, I can give you several. Smoking cessation programs use the stages of change model. Dietary change programs and similar programs all use the stages of change model. And it can be very effective because it groups people into specific stages and provides feedback on what needs to be done with those particular subgroups of the population. Next, we will talk about social cognitive theory. In this theory, people learn from their own experiences and they learn from observing other people's actions and experiences. This includes seeing the benefits of a specific set of actions and then desiring to have those benefits for themselves and thus taking action to achieve this through lifestyle modification. Now, this is one of the most frequently used behavioral theories. In the following slides, we'll discuss some of the key concepts of the social cognitive theory. Now, when we apply social cognitive theory, there are 3 key concepts that arise, including expectations, self-efficacy, observational learning, and reinforcement. I apologize, that's actually 4 key concepts. Now, expectations are the anticipated outcomes an individual expects to get from taking a specific set of actions. Can you think of potential strategy or intervention that uses the concept of expectations? Well, one example might be offering community courses that teach healthy cooking classes and show what the benefits of healthy cooking are. Self-efficacy refers to the ability of the target audience to undertake a behavioral intervention. In other words, they believe in themselves and their ability to take action. An obese individual who believes they are simply too large or cannot change does not have self-efficacy. Self-efficacy is one of the most difficult levels for an individual to achieve in terms of behavioral change. Modeling or observational learning can actually lead to self-efficacy. Modeling allows a person who needs to undertake behavioral change to see others who have successfully undertaken a similar change, and then they model their own behavior after this individual. An example of this would be Alcoholics Anonymous, in which a buddy is provided to help the person change. Reinforcements refer to a reward system associated with, well, successful change and maintenance of that change. Now we will talk about the community organizational model. In this model, public health workers assist communities in identifying and developing solutions to public health concerns in their local community. In this model, the community must be involved to achieve buy-in. There are three types, including social planning, social action, and locality development. Social planning stresses problem solving and usually relies heavily on expert practitioners to come in and assist the community in identifying both problems and potential solutions to those problems in their community. Social action's goal is to increase the community's capacity to solve problems and to achieve changes. Goals typically include policy and other significant changes that the community believes are important and which they can implement in their local community, such as no smoking regulations, bike paths, greenways, and things like that. Locality development's goal is developing group identity and cohesion, and it focuses on building community consensus and the capacity to solve problems in the local community. I do want to point out that media advocacy, such as television, radio, newspaper, public events, business sponsorship, things along those lines, are a common tactic in community organizing. That is, they use mass media to strategically advance the goal of achieving public policies. Now that we have discussed behavioral theories, we will move on to a discussion of evidence-based interventions. An evidence-based intervention is one that has been shown to be successful in other settings. But the question is, how do we define what is meant by effective? Generally, this refers to a reduction or an improvement in behaviors that resulted in a measurable outcome using a scientific approach. For example, you could look at what percentage of a community an intervention was able to reach, or what percentage of a behavior changed, and so forth. There are several key features of evidence-based interventions that we're going to discuss on the next slides. I want to point out that what I am suggesting is that you, as a public health planner or program staff, must actually go look for interventions. In other words, you must use resources such as the community guide that we'll discuss later in this lecture, or other online resources such as journal articles to look for interventions that have already been proven effective and which you can use in your jurisdictions. Now, too many times, public health practitioners design their own interventions, when in fact there are interventions already available that have been tested and shown to work. Do you know the old adage, don't reinvent the wheel? Well, it refers to public health practice as well. There is no reason to design your own version of the wheel when someone has already done the work for you. And there's no reason to reinvent your own version of a public health intervention when someone has already tested and proven so many different interventions that are out there. You just need to go out and find them and then adapt them to your local situation. Now, I can actually hear what you're saying in your head, but we live in the Pacific and things are different here. Well, yes, they are, but there are good interventions that have been shown to work in similar settings such as ours, such as the Caribbean Basin, or rural areas of the U.S. that we can adapt to the Pacific context. We are actually not so dissimilar from the mainland and Hawaii and the Caribbean and other areas as you might think. Interventions that you choose from should have been tested many times. In other words, similar results have been found from duplications of studies of these interventions. There should be consistent results between these multiple different studies, and there should have been an outside review of the results. Now, if you can find an intervention that meets those three criteria, such as the interventions that will be available through the community guide, then you know that you have a good, strong intervention that you can adapt and use for your local situation. Here are some examples of evidence-based interventions. I want to point out to you that on my YouTube channel, any interventions that I recommend, such as the childhood obesity interventions, are evidence-based and have been shown to be effective in multiple different studies. So let's look at these. So we have recommending that women be screened every 3 years for cervical cancer. Well, that's an evidence-based intervention because it's been shown in multiple studies that that is a good time frame in which to screen individuals, either using mammography or physician-assisted screening. Incorporating a physical exercise class into a school to prevent obesity. Well, multiple studies have shown that school-based interventions coupled with home-based and community-based interventions are more effective at reducing obesity in young people. Increasing local taxes on tobacco products to prevent youth from smoking. That has been shown to be effective as well. Now, like I said, I'd recommend that if you're looking for specific interventions, we will talk about the community guide as a place to get those. And then also any of the interventions, such as the ones that talk about tobacco control and obesity and diabetes control that I have on my YouTube channel, those are all evidence-based interventions as well. Okay, like I mentioned before, there are several ways to research evidence-based interventions. This lecture is going to focus on using the community guide. However, I'm going to briefly discuss the other examples that you see here. The World Health Organization's Non-Communicable Chronic Disease Work Plan was established in 2008. It's a plan to prevent and control chronic diseases focusing on middle to low-income countries, such as where most of us work here in the Pacific, in fact, where all of us work. It is a plan based on current scientific knowledge, available evidence, and reviews the experience of many different health professionals. So it's tested, it's tried, it's true. There's also the Cochrane Review, which I'm a huge fan of, and it's a collection of peer-reviewed journal articles which have been evaluated and summarized by healthcare topic. Now, once again, I hear what a lot of you are saying. Well, healthcare, we're in public health. Well, as you know, there's a great overlap between nursing and medicine and public health, and so a lot of the interventions that are suggested in the Cochrane Review are also applicable to public health settings. And I also know that I have a lot of physicians and nurses out there that listen to these lectures. So the Cochrane Review is very useful for you in your day-to-day clinical practice in finding interventions that are useful for your patient panels. Now, each review in the Cochrane Review addresses a question about a treatment or state of a disease in the world, and summaries are available online for the healthcare community that you can access and you can use in your practice. The Cochrane Review helps establish standards for the treatment of disease that can be used by like the U.S. Preventative Medicine Health Task Force, as well as for healthcare practice. All right, so now that we've covered the WHO NCD action plan and given you a brief overview of that as well as the Cochrane Review, we'll go on and we'll talk about the community guide in the next couple of slides. Now, the Community Guide conducts systematic reviews of interventions in many topic areas to learn what works to promote public health and what doesn't work in promoting public health. Now, the topics that are presented in the community guide will all be evidence-based. In other words, they're only included if they've been shown to be successful. Now, the Community Guide Task Force uses the results of these reviews to issue evidence-based recommendations and findings to the public health community. Now, interventions taken from the Community Guide and adapted for use here in the Pacific, the beautiful, wonderful Pacific where we live and work, are assured of being evidence-based. As such, you can use them with confidence. Now, why would someone use the community guide other than the reasons I've already mentioned? Well, the other question we might want to ask is, how can these systematic reviews be useful to us out here in the Pacific? Well, compared to individual studies that provide intervention about specific programs and policies, the Community Guide offers a larger body of work that can help you find answers about whether or not a type of intervention has been shown to be effective. So in other words, we can find answers there. The Community Guide Task Force uses the information from multiple different studies to develop recommendations and findings. So the Community Guide can assist decision makers and program planners in selecting effective interventions that make the best use of scarce resources by answering the following questions. What interventions work to promote good health behaviors? And are certain interventions cost effective? And also, what gaps exist in the research? So we can use the answers to those questions to determine what interventions we want to implement in our local community. And then when we implement them, we can do it with the sound knowledge that these are evidence-based interventions. So here's an example of how to use the Community Guide to increase screening for certain types of cancers in your community. Now, I highly recommend that you take time to access and learn how to use the Community Guide. It is an incredible resource that takes much of the guesswork out of how to conduct effective and evidence-based community interventions to change behaviors in relation to NCDs. Now, I'm not going to go through the steps here of how we would look at finding recommendations for colorectal cancer control, but you could look through those individually, and then you could actually use this as an example, almost a template, to go to the Community Guide website and learn how to use it. Now, one final point before we finish our presentation here. There are some non-evidence-based decision-making considerations that you should consider before selecting an intervention. Now, examples of non-evidence-based decision-making considerations might be resource constraints, such as money and people to help implement or monitor a program. The feasibility considerations might include whether the intervention is appropriate for the target audience, whether it is feasible given the capacity of your organization, whether it supports any of the program goals and objectives previously established by your organization. Of course, you want to consider political support, whether the leaders and politicians in your community will support or hinder the intervention or the policy. And of course, you have to consider the cultural environment, whether the intervention is appropriate for the culture in which you are currently working. Congratulations! You have now completed the final lecture in the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. Yay! Hooray! Clapping in the background, okay? I'm very, very proud of you. I'm proud of your hard work and your dedication. So, what do you do now? Well, just like before, please send me an email letting me know that you've completed the final lecture. Once I receive that, I'll go back and verify that you've completed all the preceding lectures, and I will issue you your Certificate of Professional Practice. And I personally designed it, and I hope you'll be pleased with it because I put a lot of effort into it. Now, unfortunately, because of budgetary constraints, we are, after all, doing this on a limited budget, I can't send you a hard copy. Oh, how I wish I could send you a hard, beautiful copy on, nice, thick paper that you could frame and put on your wall. But I will send you the PDF, and what you can do, and what I hope you will do, is you'll be proud enough of your achievement that you can go to your local print shop and you can get your Certificate of Professional Practice printed out on nice, thick cardstock paper and frame it and put it on your office wall. Because frankly, I think it's something you should be proud of, particularly as it shows your dedication, not just to epidemiology, but your dedication to the fact that NCDs are the major burden that we are dealing with here in the Pacific, and you now have a level of knowledge and understanding on how to address that using evidence-based epidemiological approaches. I do want to point out that when you receive your certificate of professional practice, it's going to have a logo on it, and the logo is a picture of a well. All right. Actually, it's not a picture of a well, it's a picture of a water pump. And what this refers to is Dr. John Snow. Now, Dr. John Snow is known as the father of modern epidemiology because he conducted one of the first epidemiological investigations using modern techniques that we still use to this day for a typhoid outbreak in London in the mid-1840s. And so he used things like mapping and the epidemic curve to determine the source of the outbreak being water from this dirty pump in a central area of London. And so that's why I use that and the date 1848 on your certificate of professional practice. You'll also notice that there's some Latin in that logo, and it's Manus Sorridae and Mens Pura. And what that stands for is it basically is the motto of the modern epidemiologist. It means dirty hands but a clean mind. And it refers to the fact that sometimes in epidemiology and public health we have to go into the field and we get our hands dirty and we work alongside the populations that we serve to try to improve their health. But we also have a clean mind, a clear mind, and we use scientific evidence and evidence-based approaches to develop interventions for those populations that we serve. So, I hope that when you receive your certificate of professional practice that you're proud of it. And you're proud that you're being welcomed into this global community of epidemiologists that are serving not only the needs of the Pacific, but the global needs of infectious disease, chronic disease, non-communicable diseases, wherever your career and your practice might take you. Now, some people have asked me, well, what can the certificate be used for? Well, the certificate can be used for a wide range of purposes, including professional development credits for licensure, such as for our physicians and our nurses and our nutritionists and our pharmacists and our optometrists and all of those wonderful people that have to maintain licensure out there. Okay, can be used for that. Can be used for employment advancement purposes with your local human resources department. Take it and show it to them, all right? Show them, I worked hard on this. Maybe this is worth a raise in pay or an advancement in my position. Can be used for seeking employment in epidemiology-related fields. It can be used for seeking admission to both undergraduate and graduate programs by showing your dedication to the field of epidemiology. And of course, as we mentioned all along, it can be used for enhancing your ability to do your job in a more effective and efficient manner. Well, once again, congratulations, and thank you as always for your dedication to public health in the Pacific. You make the Pacific a better place every day. You may not always get the recognition you deserve, but know that you're the unsung heroes of healthcare and public health in the Pacific, and I'm thankful to call myself a colleague to each and every one of you.